Thank you, Mark, for the very kind introduction. And also, I'd like to thank Harry and Adam for inviting me to talk on this very special topic, therapy-induced flares associated with surface antigen decline. And I will cover some of the novel agents, including ASO, anti-PD-1, stop loops, labs, and also siRNA. From time to time, we see patients with spontaneous ALT flares, and this can happen both in the E-positive phase or the E-negative phase. And it was estimated to be around 27% and 10% respectively. And these flares sometimes can result in E-cell conversion, and some people will also end up with surface antigen zero clearance, which is a better outcome for the disease. It should be noted that in different clinical trials, they use different normal ALT levels. Some would use 40 to 45 for both sexes, and some would use 35 for male and 25 for female. To define ALT flares, we usually refer to the ALT levels greater than 2 or 3 times the upper limit of normal for those who had normal baseline ALT. And for patients with elevated baseline ALT, we usually define ALT flares at least increase of twofold from the baseline. In fact, flares is actually not bad sometimes. And in our most recent study, looking at spontaneous flares with patients with ALT greater than 10 times, in fact, we actually have a discussion in the last section. When we follow up these patients with very high flares, they actually had a higher chance of getting subsequent surface antigen zero clearance after follow-up. However, if the flare is severe and uncontrolled, we may sometimes encounter the risk of liver decompensation and even mortality. How about patients who receive treatment? And we know that patients who received nucleoside analogs, sometimes we encounter patients with flares, and they usually subside spontaneously. How about patients receiving new treatments? We know now that patients receiving new treatment that can lead to surface antigen reduction, and that we always say immune awakening, that will also be associated with flare. But in clinical trials, we also need to look into whether this flare is related to what we call drug-induced liver injury, DILI. And we now also advocate the stop loops therapy. And in that particular context, this patient's flare will be related to the rebound of the viral replications, and that induces the immune-mediated attack. There are some important clues of flares when we manage the patients that will give us some idea whether this is related to the drugs or related to the disease-related activities. Firstly, the timing of flares. Obviously, if the flares occurs during treatment, then we will think about whether this is hepatitis B-related flares or the drug-induced toxicity. If the flares actually occurred after stopping of treatment, we usually think about whether this is related to the activities rather than the drugs. Secondly, in a more granular level, the temporal relationship between the drug administration and the flares is very important. And that can be taken into consideration for us to decide whether it's likely to be drug-induced or hepatitis-related flares. I will show you another example in the subsequent slide. And finally, if we can observe an obvious association of the reduction of the viral materials during treatment, then we will think that they will be more likely to be lowering the surface antigen because of the new drugs, and that induce the immune flares, and sometimes we call it good flares. So in this particular patient, he actually received siRNA at every 4 weeks. And after the first dose, the ALT actually increased to around 120. And then, after the second and the third dose, the ALT actually increased to around 140 to 150. And the highest ALT of around 200 was observed after this fourth dose. And then subsequently, these patients had the flares of ALT around 100 and below 200, and then subsequently subside with normal ALT after finishing of the therapy. The absent, or the fact that there was no further upsurging of the ALT after the fifth and the sixth dose may more indicate the flares are related to the surface antigen lowering effect rather than drug-induced toxicity. However, we cannot totally exclude the possibility of DILI in this case. That comes with the importance of lowering the surface antigen during therapy in patients receiving siRNA. And we still don't know whether these flares are more likely to be immune-related due to the surface antigen reduction or DILI in this particular case. To illustrate the point of, or the importance of knowing the surface antigen level during therapy, I would like to illustrate two examples to you. The first patients actually had the ALT flares just after a very rapid decline of the surface antigen of around 2 log after a single dose of siRNA. And the second patient below have three episodes of flares. The first two actually coincide with a 1 log reduction of surface antigen after the single and the multiple doses of siRNA. And in fact, the last flares was actually well after the completion of the siRNA treatment, and in fact, was related to a concomitant febrile illness in this particular patient. We always say that, the low surface antigen lowering effect of siRNA will induce or reawaken the immune system, and this study supports the hypothesis. And in patients receiving HBsAg siRNA, we identified 7 patients with documented upregulation of the hepatitis B specific T cell activation, and that was, reflected by the measurement of the interferon gamma, illustrated in the brown bars in the diagrams. 5 patients had the ALT flares, 5 patients with interferon gamma production coincide with the surface antigen decline. And some of these 5 patients actually have coincided with mild to moderate ALT elevation. And 2 patients actually have the interferon gamma production after the completion of the HB729. Similar to what we have observed for patients with spontaneous ALT flares leading to surface antigen seroclearance, we also see patients who received no full therapy with or without interferons leading to the loss of surface antigen. And in these 3 patients, they actually received VIR-2218 plus pegylated interferons, and you can see that the ALT actually the ALT flares actually occurs during the declining period of the surface antigen. And after 24 weeks of therapy, these 3 patients actually lost the surface antigen. Similar to what we observed in the siRNA, we also observed the association between the flares and the decline of surface antigen in patients receiving antisense oligonucleotide bepirovirsen, BEP in this case. But I would like to draw your attention to the magnitude of the ALT flares in patients who were already on nucleoside analogs. And you can see that these 3 patients have flares after the surface antigen decline. And in fact, the peak ALT during the flares were around 200 or 250. And they all actually, spontaneously subside, even without doing anything for these patients. However, when we look at another patient who received the same regimen of the ASO, who is not on nucleoside analog therapy, in fact, you can see we can see the temporal, association of the surface antigen and also the ALT flares together with a DNA reduction. But you can see these patients actually have the very big, flares in terms of the level of the ALT compared to the 3 patients who are on nucleoside analogs. These patients have the flares of 800. In addition, what they've observed is they find there was an association between the magnitude of surface antigen reduction with the ALT AUC, meaning that the greater the surface antigen reduction, the higher is the ALT during the flares. In addition, as mentioned, patients who actually were naive, they actually have a higher magnitude of ALT flares during the therapy. Not only we see, the ALT flares and the surface antigen decline association in siRNA and also ASO. People receiving other novel therapy, in this case, for example, the surface antigen release inhibitor, the NAbs, actually also showed a similar phenomenon. You can see in both cohorts, with the profound decline of the surface antigen after the administration of the NAbs, there are many patients who actually have ALT flares. And not only that, further analysis showed that, similar to ASO, they actually find there was a correlation between the magnitude of surface antigen reduction and ALT levels, but only limited to those with surface antigen reduction greater than 3 logs during the therapy. And patients who achieved functional cure subsequently has a trend of lower surface antigen level at the time of flares. So all these actually indicate that the association or the relationship between ALT flares and surface antigen actually exists in patients with receiving different novel direct antiviral agents. So the question is whether would it be the same observation in patients who receive immunomodulators? This is a study using the lock nucleic acid liver targeting anti-PD-L1, treated the patients with 5 doses. And you can see, although the mean surface antigen level was not particularly high, around 0.3 logs, but we can see one patient, at least, who had a very nice drop of the surface antigen represented in the blue line, accompanied by an increase in ALT represented in the brown line. So we did see patients with receiving anti-PD-L1 having the association of surface antigen decline together with the ALT flares. And monoclonal antibodies, in this case, envafolimab, targeting the anti-PD-1, also showed the similar things. ALT flares was observed in 21% of patients, and 9 out of 10 patients with the flares show a very obvious downward trend of the surface antigen. And in fact, they have 3 patients with sustained surface antigen loss, and 2 of them, they had experienced ALT flares. And this is the diagram showing you the serum profile of this one of the 2 patients with ALT flare ending with surface antigen loss. And these patients actually had the cessation of both the anti-PD-1 and the LUX, and the surface antigen remained to be undetectable 24 weeks after stopping both treatments. So we discuss the patients in greater detail with ALT flares during the novel antiviral therapy. And how about stopping loops? Whether it occurs or what is the outcome of stopping loops. And in fact, I think Professor Lampetrico will also discuss it in greater detail. What I'm going to show you is the results of stopping loops of patients with 2 cases. And in fact, before that, the benefit of stopping loops, we know that is the occurrence of the surface antigen seroclearance afterwards. It was estimated around 13% after 4 years of stopping loops. And you can see that white patients had a significantly higher chance of getting loss of surface antigen compared to Asian population. However, around 30% of these patients who stopped NUCs had the what we call ALT flares. And sometimes we see patients with liver decompensation estimated to be around 4.5% in cirrhotic patients and 0.8% in non-cirrhotic. And sometimes we see mortality out of these, flares. So we always strike the balance between the risk of liver failure versus the benefit of achieving functional cure when we consider stopping NUCs. And I think, personally, I think the key important factors is the patient selection and also the monitoring strategy for patients who opt to stop NUCs. And this is one example of our own trial, stopping patient NUCs, and then we find that 21% of these patients actually have ALT elevations with flares, and 4 actually developed grade 4 ALT elevations. The peak of these 4 patients was around 1,324. And this is a profile or diagram showing you the profile of the ALT together with the DNA at different time points of these particular patients. And you can see over 1 week, actually the DNA actually increased by 3 logs. And in fact, there is no ALT elevation at this particular time point. And after 4 weeks, another 3 logs increased. And at that time, the ALT was already 475. And then we start the patient with entecavir, and luckily, these patients actually had a control rapidly of the DNA, and with the peak of ALT 1,300. And for that particular patient, we successfully, or luckily, I would say, contain the flares. However, this, I think, Professor Lampetrico will also talk about in much more detail. But in brief, even in a very well-defined, controlled clinical trials, we sometimes encounter very bad flares, very rapid flares, resulting in liver decompensation with a poor result requiring liver transplantation. So, ladies and gentlemen, I would like to conclude by saying that ALT flares are common in patients receiving surface antigen-lowering agents, including siRNA, ASO, NAP, and anti-PD-L1. The chance of ALT flare seems to be correlated with the magnitude of surface antigen reduction, the rapidity of the surface antigen reduction. Preliminary studies showed positive T-cell activation in close relationship with the surface antigen reduction and ALT flares. ALT flares is comparatively less severe in NUC-treated patients compared with treatment-naive patients. ALT flares, because of the surface antigen reduction by novel agents plus or minus activated interferon, can result in loss of surface antigen. And ALT flares can be very severe in patients who stop NUCs, and we really need a very cautious approach for monitoring for these patients. With that, I would like to thank you for your attention.